And Dr. Bobrowski, it looks like we have 3 of the 5. I have you and Joe Petrie, John Gray. If I've missed anyone, please let me know. But it does look like we have a quorum.
Okay.
And I will turn it over to you.
Okay. Well, we do have a quorum, and I guess you could kind of officially have done a roll call just now. Will that suffice? Okay, Miss Kelly? Or Kelly, can you hear me okay?
Dr. Bobrowski, we cannot hear you.
Can you hear me now?
I can hear you, Dr. Bobrowski. Can you hear me?
Yeah.
I can hear you.
Yeah. Okay.
Yeah, I hear you.
Okay. Well, we'll go ahead and call our meeting to order of the dental TAC, and this is Dr. Garth Bobrowski, and I wanted to welcome everyone here today, and we want to hopefully we have a very good and interesting meeting, and I just kind of wanted to kind of start us off, and I've got just a brief report that I wanted to share with you all, as more or less as an example of things we could look at doing to help in a mechanism of preventive care, which could mean, well, like doing fillings on teeth, help the patient, number one. Number two, I think it does help to minimize the cost to the state on future root canals and crowns, and maybe even partial dentures down the road. The treatment of gum disease, the same thing. And I think I've mentioned this before on some meetings, but just the dentistry is kind of in well, I've got it down here on the report here. We're kind of in the healthy smile business. And a lot of the dentistry done out here is, we're trying to build a healthy foundation, by treating cavities, gum disease, occlusal disease, replacing teeth to maintain teeth positioning. But, we want to try to help people. And I just I was reading an article and other articles, but this one kind of caught my eye about the association of periodontal or gum disease with other systemic conditions. That's the title of the article. It was a bidirectional relationship with other health issues, kind of related to how the oral health relates to diabetes, rheumatoid arthritis, heart disease, and other related health issues related to oral health. This article came out of the National Center for Biotechnology Information in association with the National Institute of Health, through the National Library of Medicine, and also in association with work being done by Boston University School of Dental Medicine. I want to try to be kind of quick and brief on this, but just to give you an example on things. But the part of the article talked about probing depth is a good indicator of the advance of the disease of gum disease. Of course, dentistry also, you have to look at the x-rays. You look at the color, texture of the tissues. You count in the fact, are they diabetic or have other health issues that could advance the disease. This was a new item that they put out in this article, is that clinically, patients with periodontal pockets of 4 millimeters or more are now to be diagnosed with periodontitis. The gold standard used to be the 5 millimeter pockets, and in some circles it may still be 5 millimeters. But my question is why do we wait until there is bone loss to start treating this common disease. Some form of periodontal or gum disease affects 75 to 90% of the global population. My wife said the other night, I was kind of reading through some of this to her, and she said, that's gross. And it can be. But left untreated, gingivitis progresses into an irreversible periodontitis, resulting in tooth loss and gum abscesses. And again, we got to stress it. We're in the healthy smile business. And, we want to just try to get people healthy. Now, this is just an idea that I had on starting to treat gum disease in our Medicaid population is to and I was looking at some of the criteria on some of our MCOs, and some of their criteria is spot on. It's really good, but my idea would be to develop with our patients a 1-year plan of action that the patient would sign as a treatment agreement. Now, that they'll do, I guess the signature would mean that we're trying to get them some buy-in on their care. This care would obviously include a full mouth x-ray series, periodontal charting, hard and soft tissue exams, diet, smoking, counseling, and I think we need to add in a behavioral health component. Now, if this agreement is done, you've got your charting, but that to alleviate some of the paperwork that a lot of dentists and dental offices have to go through, is that if they are in this agreement and sign this document, well, then no pre-authorizations would be required through the MCOs or the fee-for-service patients. We would continue to use the same scale, root planing, appropriate codes like your D43, 41s, and 42s. But we'd also need to look at a robust code, or adding the code in of a D4355, which is a full mouth debridement to enable an exam. Now, sometimes that exam is, I think it's just used for pregnant ladies. But when you deal with young people that come in and they have acute necrotizing ulcerative gingivitis, these people are sick. They have a fever, malaise, they're hurting, they can't eat, they don't feel well. And sometimes before you can even get your probings, well, number one, I wouldn't even start to probe somebody that's got this acute necrotizing ulcerative gingivitis. They can't stand it. But anyway, to look at this full mouth debridement just to help them get out of pain and the disease process started to cure it. Add in a code of D4921, gingival irrigation with a medicinal agent. Add in the code D4910, which this would include a cleaning every 3 months for 1 year. This is a 1-year plan. Another behavioral component of this would be that the plan would have no failed appointments by the patient. And after 1 year, to reprobe and do a reevaluation to see if those periodontal measurement numbers are getting better. Now, other codes, and some of these that I've already mentioned have already been added this year, but others could be added to just let us or just help us treat this disease. Now, an idea that I had too is, instead of getting patients just to walk in the door and give them a gift card, let the patient earn that gift card now, after they've completed that year plan, not just for showing up, but just to give them that reward, if they complete the treatment plan. Also, I would recommend pay your providers a decent and fair fee, that the MCOs can't go below. We've got to do some changes to move Kentucky from the 49th in the nation on oral health care. We got to move that up. We've got to do something different. And we've got to just change the attitude of oral health care, whether it be with administrations, administrators, the dentist, the public. And this is something that you don't do overnight, but we want to just help our patients, help us treat the disease. Now that I just want to give just some ideas of trying to get us out of this 49th position in America. And I just put that out there as an idea. And it can be ignored. It can be modified. And I know most ideas tend to get modified, and that's okay. But I just want us to start thinking about ideas that we can do to move from 49th on up. I'll guarantee it'll take a while to get to number one, but we've got to start somewhere. Now, are there any questions or comments about that brief report? I'll move on. Now, I want to go to old business, and I put on the agenda, I said, please don't shoot the messengers. Sometimes I feel like we as TAC members are, we bring questions from ourselves. We bring questions from a lot of our patients. We bring questions from other dentists and other healthcare providers that we need to bring before you and let the TAC look at it, and then make some resolutions to go before the MAC. And I wanted to again thank Commissioner Lee, for working with the TAC and others and other groups to, help increase our access to giving care. And it is very well appreciated that she, listens to us and has these concerns that we do. The one thing, and I think the commissioner said earlier, is that she may have to leave early. And before I get into a lot of this other, I would like to have a time if Commissioner Lee would like to speak now or after a while, either way. So Commissioner, would you like to have the floor for a few minutes?
Dr. Bobrowski, this is Kelly Sheets. I'm sorry, the commissioner did have to step away already. So
Okay.
I apologize.
Okay.
You also need to make sure you approve the minutes from the January emergency meeting and the November 4th meeting. So just a reminder of that.
Yes. Thank you so
You're
much.
welcome.
Why don't we do that right now? We've got a quorum for our TAC members. Let me write this down here. Let me make a note here. Okay. Well, I'd like to just for the TAC members, I'd like to entertain a motion to approve the minutes, from the November TAC meeting, and then also from the January meeting.
I'll second the motion.
Did you need a motion made
right.
first? Yeah, that's okay. I'll make a motion to accept the minutes from the November meeting and the emergency January meeting. Joe, you can second it, or somebody.
Okay.
Second.
Nice.
All right. Thank you, guys. All in favor, say aye.
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 Any opposed? Okay, I believe we got that. But I'm gonna go on down. We kind of want to look at the codes and reimbursement rates a minute here. And boy, I hate to admit this, but I spent hours of time just going through the new 2023 FFS fee schedule, and I even expanded it out into Excel, and I was making some, there were some typos in there. I was just gonna go through and see what I could do to be helpful, and spent 2 or 3 days on it, several hours each day, going through things and offering some significant. Got it all. I sent it to the TAC and I sent it to the Commissioner Lee, and then somebody else later on said, "Well, where's your stuff?" And somehow, I guess when I sent it, it columns on me, and then it stuck everything at the very bottom of the report instead of lined up with each code number. And it's just, when you work on something like that for hours and hours, and boy, and then that happened, and it just took the wind out of my sail. And it just like somebody took my face and shoved it in the mud hole. But it just, anyway, we're going to work on trying to update that. And but I would encourage all the TAC members to kind of look over that fee list, and of course there's some typos in there that even were in the previous years that just kind of got carried over. But I think that since this is a state document, we can update it. And at this time, I want to look at I've got on the agenda as old business of our fees and reimbursements. One of the things I've noticed, and I've already made the commissioner aware of this when I sent all this stuff in previously, but there's even some codes in there like a D2394, which is a 4-surface composite filling code. There was nothing listed down in the new fee list. When I went back and compared it to some of the older lists, it was there. But those are some things that we just need to tidy up our list. And if our TAC members could look at those and just see what else we can help work on that. Now, TAC members, does anyone else have any comments on the fees and reimbursement so far? Now, whoever just spoke, I could not understand you. It was muffled. I'm sorry, I still could not hear that. Can anybody else hear it better?
No, I cannot hear it at all.
Okay. Phil, Dr. Phil, did you have any other comments so far on fees reimbursement?
Well, I know there's some confusion about some of the fluoride codes and, having to wait a number of weeks after we do fluoride, but I think there was some confusion as to which fluoride codes we were looking at. I think one of them was diamine fluoride, which, you don't want to do diamine fluoride on a tooth and then, restore it, a week later. But, some of the full mouth fluoride treatments, there shouldn't be a restriction on doing restorative, after that for I think the restriction was 3 months. if I remember correctly. And I don't have the code numbers in front of me. Sorry.
Let me see, I can look it up here.
Yeah, there was a waiting period on restorative after after a fluoride treatment, which didn't make a whole lot of sense to me.
Now, on the,
And I had the same question about the four surface posterior composite missing.
on the fee list that I've got up here, this was revised January 30th. On the fluoride there, I don't see anything. Are you finding that, Dr. Phil, in the MCO manual?
No, I think it was on. I think it was on the one that was from. I think it was one. So it may have gotten cleaned up on the next version.
Okay, it just shows on the fluoride, they say the exact same thing, whether it be a fluoride varnish or a topical application of fluoride. It says limited to 2 per 12 months per member per provider. And that's the same. I don't see any other restriction on there. And like I said,
Did
this
you
has
did you talk to the
revised.
commissioner? Yeah, did you talk to the commissioner about the pre-authorization for the was it periodic exam code that was on there initially?
I did not. It's now, yes, up there. It's the it's the DO-120 periodic oral exam or oral evaluation, requires prior authorization 1 per 6 months. I sent that in to her, but I did not talk with her about that particular one yet. And I believe
Well, I
she
can't
has
imagine
a,
the MCOs are going to be able.
yeah, I don't even remember
Go ahead.
that being on.
This is Carol Braun. I know I noticed that as well, because historically DO-120 wasn't a covered service. You had to use the DO-150 for each encounter. And so I just wasn't quite sure how to direct my staff to code out exams. So
Yeah, if we could get some clarity on that, Garth, that would be good, because obviously the MCOs can't, even handle that. I mean, can you imagine having to pre-authorize every periodic exam in the state?
well, and then also for the DO-150 now to be limited to 1 every 12 months, that's not something that had happened before either. So it's a little bit confusing on that.
Garth, this is Jerry.
Yes, go ahead.
Avisus is not requiring a pre-authorization for a D0120. And we made the same suggestion to DMS that you did.
There, this is Lauren.
I know.
Oh, I'm sorry.
No, you're fine. Go ahead.
I was going to go ahead. This is Lauren from DentaQuest on behalf of Anthem. We're not requiring the prior authorization either.
Yeah, but of everything on the new code list, I'll be honest with you, that was the one that had everybody about as riled up as you could be, just because of the amount of paperwork. And obviously, we don't have the capacity, and the MCOs evidently don't either. So we got DentaQuest and Avisus are not gonna require that. So I guess we get United Healthcare will be in business.
We're not
Dr.
gonna-
Ad,
I don't know if you can hear me.
yes, we can.
Yeah, we got you.
Yeah, we won't be requiring that.
Okay. Well, thank you all.
Sounds like it's a moot point.
Cleared that up real quick. Thank you all so much. And of course, basically on the DO-150, I mean, that's what I understand. That was one you could only use it once a year, which that's basically what it says out there in the notes, is 1 per 12 months per member per provider.
What you can do, Garth, then is for the second one each year, you can use the 120 though.
Right, yes. So, Dr. Phil, that's how I do it, is I use the 0150, like say at the first of the year, and then, or when it would, for their first appointment, then in 6 months, we just use the D0120. But you just have to tell your
Yeah.
front office staff, make sure they're doing that correctly. There was some of the wording on these fee lists was what I was looking at. Sometimes it can be just a little confusing, or especially if in this day and time when you have staff turnover, just training them on things to how to file things and not try to eliminate the refiling things. And and I know one of the questions was why is there a different fee for like a upper denture as compared to a denture fee on the lower denture? And what I was told was that statistically, when they looked at the national trends of the payment on dentures, the upper denture typically was charged more by dentists than the lower denture. Now, I don't know, when I price dentures to patients, I tell them, oh, it's the same price for each denture. I don't know why dentists have two different prices for basically the same procedures, just a different arch. If anybody knows that reason, chime in. But there was one other one.
We do it
Well,
just like you described, Garth. I mean, it's the same.
Okay.
It's the same fee for the top or the bottom.
Yeah. See, here was just an example of one of the wording changes that I had recommended, was under denture relines. Well, there's plenty of room to kind of spread those out, but it's a D5731. It says denture reline complete mandible direct, or it's spelled, they just put DIR. Well, the next code is a D5740, and it just says reline maxillary. Well, that's a partial denture, but it's almost like, then down there is the word for reline complete maxillary denture, a D5750, but just some of the wording, I think, could just be matched up a little better. And I'm just looking at it from helping to training staff, and as we look through there on those codes. Let's see, did John Gray ever get on the call? He's our oral surgeon. I was just going to ask if he had any questions on any of the oral surgery codes. Now,
I have not heard any comments coming from our oral surgeons, other than thanks for the increase. I mean, that was nice, but I've not heard any confusion or anything that didn't make any sense from any of my folks.
okay, good. Now, I don't see it on this new code list, but on some of the previous ones back there earlier on in January, and that was what I put it on there. There was a column that was just kind of, it was marked in green out to the side. Is there anybody from the state I don't see it on the new one, but what was that for? I never could find out what that green column was for.
Garth,
Ms. Kelly?
the green column was for the codes and the fees that were going to be shared between oral surgery and GP. So if it had a green code, that was the same code for oral surgeons and GPs. If it didn't have a green column or a green square next to it, then that fee only applied to oral surgeons. That was
Okay,
my understanding.
okay.
This is Kelly Kitchen with DMS. Can you hear me okay?
Yes.
Okay. So that is correct. The green
You're
column
breaking up a bit.
is there for the oral surgeons, and we moved that piece to the lower portion of the fee schedule. As far as the wording that you were speaking of, DMS received a file from the AMA from CMS that lists a short a description of a code, and also it lists from the from the ADA. It lists a short description and a long description. So most of the time we use the short description, but we can definitely look at updating that to use the long description. That would make more sense.
Sometimes when you're just going down through there and, and looking at things just on making stuff just easier to find.
Absolutely.
Well, we'll just have to talk to that ADA about that stuff. No, I'm joking. Now, are there any other comments or questions about anything of these other codes and things? I think some of that has, well, I guess the other thing is like on, and I did mention this to the commissioner on like dentures, partial dentures. Now, yes, some of the codes are, the requirements or pre-authorizations are done by the MCOs, but what are the guidelines, pre-authorization requirements, et cetera, for patients that are on the fee for service? Because some of those, of course, those little squares don't have a whole lot of room. But how do we find out that information? Because we've got people calling every day wanting, partial dentures or a denture or whatever. And we're a little hesitant to start something because we don't have all the guidelines printed out somewhere yet that I can find.
This is Justin Derringer, Department for Medicaid Services, and Kelly can correct me if I'm wrong. I thought we had covered this before multiple times, but you talk about something so much you forget exactly where you talk about it. And so we have maybe we should put out some guidance, I guess, on a website, because I think this has come up multiple times. But all of the requirements that we have are listed on the fee schedule. They're right there in that column. If there's not anything there, there are no requirements for that particular code. We do have prior authorizations where we use, clinicians to review for appropriateness, and then all codes are open for auditing to look for medical necessity. But if it's not listed on that fee for schedule, fee schedule or fee for service fee schedule, then there's nothing for that particular code. And if you see something that you may think, well, I think there should be something there, like we've said, feel free to reach out and submit that information along with all the other codes that you've talked about up to this point. submit that to us and we'd be more than happy to look at that. And, since this is a first time fee schedule, I know we're not making any changes for a while to it because at some point we had to stop and say, this is the fee schedule. But we usually do changes to the fee schedule once per year. However, for this one, since it's new, we may consider doing something after 6 months or so. But we need to have all the information and absolutely, if it's a typo, we can change that. Because it's already changed in the system one way. Anytime we make a change to the fee schedule, we have to make a change to the system as well, which usually takes a number of months and is usually a price tag involved also. But so anything that you feel like that's missing or been left off, we encourage you to write that, send that to myself or the commissioner, either one, and we will review that and see what we can do on this 6 months that rolls around. Maybe we can do an update at that time.
Would you mind to give us your email address then so that we can send stuff, we can send it to you and copy the commissioner or vice versa?
Absolutely. I'll put it in the chat right now.
Okay, good. Thank you very much, Justin.
And Dr. Bobrowski, I'll send that out to the TAC members as well following the meeting.
Okay, great. Thank you. Let me make a note here. Well, just for sure, there's down under that D2394, there's no fee listed for it says resin, 4 or more surfaces posterior. And I know
Yeah,
there
I
used to
heard
be
you.
one.
Yeah, I heard you talk about that one earlier. That may be a typo. We'll just have to kind of go in and look and see, but get those together. We'll look at those. If it's anything that's a typo, we've just accidentally left off on the fee schedule. It's probably already in the system, so we just add that to the fee schedule and we're good to go. And any other suggestions we can look at possibly. Like I said, since it's a brand new, I understand it's not a brand new fee schedule, but it's a brand new fee schedule in the sense that we have created an additional group of people to be serviced, and we've also included a lot of additional codes and pricing, and because of all that, we may want to do a revision at the 6 month mark, which is not something we normally do, but with this one I think we might need to. But yeah, absolutely, send me that. I've got that one already. But you can send me that one and all of them that we've talked about, or any that you see after this. If you want to, encourage the TAC to go back and relook at anything they may have a question about, any suggested improvements, anything like that. We're always and it's not just for this fee schedule. It's something that I try to tell all provider types. We're always open. We constantly get emails from providers, from provider advocate groups, from TACs, from MCOs, asking about different codes or pricing or requirements. And so we're always looking at and doing research on requests we get and suggestions we get from the provider community about all types of different things. So this is something that is built into our process and our program, and we look forward to it.
There's in my little report this morning on treating the gum disease, and I've already mentioned this to the commissioner, but down there in treating gum disease, I know the fee, it's a D4341, and I know the MCOs and the fee for service, it does require prior authorization. One thing that I know some of the MCOs require is that we can only pre-authorize 2 quadrants at a time. Now, this is a new change over the last few years, but instead of pre-authorizing and if somebody from one of the MCOs wants to chime in here in a minute, please do. But it's just that by not being allowed to do all 4 quadrants at one time, then we get 2 done, then we've got to go back, and it just takes up more time from our front office staff to then we've got to send in 2 more quadrants to get done. I just kind of like the old way. I just get in there and get it done. And most, I don't know the way we do it in our offices, we usually do 2 quadrants at a time. But I'd just like to decrease the paperwork time it takes our front office staff, so that if the MCOs would consider just doing 1 pre-authorization would be nice. But at the other hand, looking at those, the 43, 42, sometimes to get somebody in and numb them, deep scale them, put a medicated rinse on them, and the fee for the adult is $26. I can't do it for that. Therefore, I can't treat the disease. These are, to me, this is just as much of a preventive process, a preventive treatment code to help prevent the disease from getting worse. It's not through their whole mouth, but it's in a section of 1 to 3 teeth. Typically, it's around the molars, but I can't do it for $26. So we need to look at that fee on that one, and I have mentioned that to the commissioner on that one.
Was that the 4341? Is that what you?
Well, the 4341, that
was the
code,
prior authorization. So what was the code?
Right.
Yeah.
Well, it's the D4341. That the fee on that one is only at $78, for an adult, and it's paid at $101.40 for a child. Well, I don't, in all my years of doing dentistry, we don't have to do much root planing on children or teenagers. But that's another fee that needs to be looked at, or at least raised up to the children's rate. And then the D4342. If you really want to get serious about treating gum disease, you got to get it to where it costs them that much just to do the paperwork for some of this stuff.
Hey, Garth.
Yes, go ahead.
Before we get off of fees, I was asked by some of our leadership on the oral surgery side about implant codes. I've not seen implant codes on the fee schedules. So I don't know if it's on the 130 revision that you had talked about, but the patients are obviously asking a lot about implants, but at this point, I don't think we've got a lot of guidance on, what's covered. And I mean, I've talked to Dr. Caudill about, some of the clinical requirements, but I don't know if they're listed on that fee schedule, or if even if the code's listed.
Yeah. There was an endosseous implant code right there. It's a D6010. Now endosseal implant says prior authorization required. Implant must be based on last resort dentures that are causing damage or not wearable due to medical reasons, once per tooth per lifetime. So somehow to get the pre-authorization passed through, it would probably be like you'd have to probably write a narrative where the denture is either causing damage to other tissues or just flat not wearable due to a medical reason. And I guess the fact that there's no ridge left would be a medical reason, and they've already tried a denture. Any of the MCOs got a comment on that part yet?
I think as long as it has to be pre-authorized, these are obviously going to be few and far between. I mean, the
Yeah.
patients think that every time they have a tooth missing, they're going to be able to get a free dental implant. And that's not going to be the case. And
Right.
as long as we got a pre-authorization process to go through, we'll work through it on a case by case. I just wanted to make sure it was on there.
Yeah. And I know, let's see, and then a while ago, when I was giving my report, I know, we do and Dr. Phil, it's just like I know you all do a lot of gum treatments. We do too. And they have added in the code to D4910, which is a periodontal maintenance procedure. And if you're going to treat gum disease, I know it's standard of care to have a cleaning done and typically it's at the gum specialist, or sometimes they'll alternate every 3 months with the general practitioner's office of just getting a good cleaning done. And then they do monitor the perio probing. So, but now this is what's on here is for the fee for service. And to be honest, I haven't looked at the new fee for service for the MCOs to make sure that the MCOs are going to follow through with that too. But those are some codes that are being added that I know as a practicing dentist that those are appreciated because we can actually help our patients more by doing this follow-up care than we could in the past. So that is appreciated. And I want to say a thank you again.
Dr. Bobrowski,
Yes.
this is Dr. Cottle. On the periodontal maintenance,
Yes.
the visas did reach out to both the University of Kentucky College of Dentistry and the University of Louisville School of Dentistry. I spoke directly with the head of the periodontal department of both dental schools. Avisis is recognizing periodontal maintenance every 3 months.
Okay.
Following
you very much.
Following, definitive periodontal therapy.
Yes. Yes. Yeah. But do you all, Dr. Cottle, in your research, and I know you've been a practicing dentist too, am I correct in saying that 3 month follow-up is pretty much standard of care to help keep the disease process to a minimum?
That's what both dental schools said. Yes, that is still the standard of care.
Good deal.
And that's what they're still teaching at both dental schools.
I'm gonna make a note here. Well, thank you all for that. DentaQuest and United Healthcare, have you all had a chance to look at that code?
This is Chrissy from DentaQuest. Yes, we are basically in agreement with Dr. Cottle and Avisis's approach there for those codes.
Okay.
Yeah.
Thank you very much.
Yeah, this is Dr. Rich with United Healthcare. We'll follow standard care guidelines as well.
Okay. Okay. I hate to put
Garth.
folks. Yeah, go ahead, Phil.
Could we maybe talk to the MCOs about that 4-surface posterior composite? I mean, even though it may not be on the, even though it may not be on the state fee for service fee schedule, is that something that they will continue to cover? We can't, because I mean, if it was a typo and it was left off for real, we can't wait 6 months for that to be a covered procedure. We do a lot of 4-surface posterior restorations on this population.
Yes.
So I know that for DentaQuest, if something is not covered yet, it's medically necessary under EPSDT, it is payable. So it would just kind of really depend. Even though it's not on the fee schedule, there are those instances where it should be allowed.
And it could be allowed under children under EPSDT, but that would not affect adults. And actually, the state's fee schedule is showing, I'm looking at it right now online, it's showing it's covered for children, but not for adults. It says in C. So
Right.
I guess we're all hoping that's just a typo that they can quickly fix.
Yeah, because that's one, Garth. I mean, we need to get an answer on that one pretty quick, because I mean, can you imagine how many four-year composites are done on Medicaid patients in this state?
I do a ton of them, you know, and
the problem is a lot of dental offices don't even have an amalgamator. They don't do silver fillings anymore. They only do composites.
Right.
Yeah, right. Yeah. Now, Dr. Cottle, are you all still just doing it under as a EPSDT on that?
Until this is changed, we're following exactly what's printed. Yeah.
But I mean, to have to go through the EPSTD for every single one of these would be, that's a burden.
Yeah, but that's not, my understanding is, Dr. Rich, that code's always been covered for under 21, and EPSDT only covers under 21. That's the adults that have not been on the fee schedule for. And
there you go.
But UHC's been covering it for adults, but it's not on the fee schedule, the prior fee schedule or this one. It doesn't really make any sense. I don't understand it either. I think we're all in the same quandary why it says not covered, but it is covered for our UHC members. I know that.
I want to put this down just a second. I'm going to look something up here.
While Garth's looking that up, Dr. Caudill, did I understand that if it's not on the fee schedule, you all are not covering it?
I believe that's what I was told on the last version of our fee schedule. That we're following DMS exactly.
Well, Justin, I want to hopefully that I know it's Friday afternoon, but well, we've got to get this one figured out.
Yes, sir. Yeah, it's just like I said, I don't know if it's 3 o'clock on Friday afternoon. We'll do our best to try to get an answer for you all as soon as possible.
Okay, appreciate that, because just
Absolutely.
to follow up and see if it's just a typo or if it is just accidentally got left off, because out here in our world, we have a lot of folks come in with, whole sides of teeth busted out or decayed out. And we do a lot of that type of repair. And we're six weeks or so into the new year, and it's untelling how many of that times that code's been used.
Garth, can we get a comment from DentaQuest? I think that's the only one that we really haven't heard from.
I think she said they'd use the EPSDT.
But you can't do that on
wrong.
adults, right?
Yeah, EPSDT is for children only.
Yeah, it's for children only. So it would just go down to medical necessity. In the event there's like a true medical need, right? Sometimes they'll be covered for the adults.
Okay. I'm making a note here.
I hope so. I'm making a big one.
Yeah.
It's this is Lauren from DentaQuest. Sorry, I was just going to add that they've been covered for adults. We just require to show the medical necessity. So just perio charting and x-rays.
See, that's the thing that bothers us practicing dentists, is that, historically, something walks in the door. They've been up here at the restaurant at lunchtime and broke the side out of a tooth, and now it's 1 o'clock in the afternoon and you got to fix it. Well, no, I may or may not have done a periodontal exam, but I can see on the X-ray that I don't see any bone loss. But if I've got to send in a a pre-authorization or an X-ray and a perio charting, just to fix that tooth that I can, in my professional judgment, don't see a bone problem or a fracture that's going to cause the tooth to be weakened. That's what I have a problem with, is the paperwork that's involved with just treating people. We've got to figure this out. But the other thing is that, and it's down here in new, well, no, it's here just in the next item. It's like we as Medicaid providers, we've lost a ton of providers. And my question is, how do we get them back? And boy, you don't get them back by having a bunch of paperwork and stuff to send in. If you've got somebody out there that's an outlier, go after them. And I've talked to other practitioners, not even in dentistry, that sometimes the paperwork involved is just denying treatment for people. I mean, you take it like if you had a broken tooth right after lunch and you did get into a dentist that afternoon, well, would you want the dentist to say, well, I can fix that, but I've got to wait until I get the authorization back from your insurance company or from your Medicaid company? When can I get that back? Well, how long does it take to get it sent in and get an authorization back? But that's my problem as just a practicing provider. And that's the other problem, is as other dentists drop out or limit their services to the Medicaid program, then for the ones like me and some other dentists around and across the state, it's like we try to do everything we can, but that puts even extra burden on us as other people are dropping out. And I'll tell you, and it was shown by Dr. McKee's presentation and survey, that these failed appointments was another problem. We talked to a dentist, and there's two dentists in another town close by, but they've limited their practice to like 1 4-hour segment a week. I think I may have mentioned this before, but he called me again the other day, last week, and they had 21 patients scheduled in that time block. 10 of them didn't show up. And again, I think things we need to look at, and I'm going to ask the MCOs and the state to kind of look at this, because it's a factor that's causing dentists to lose out. And I'm on the MAC, and this failed appointment problem, it's a problem across the state with multiple health providers. And I think we need to get creative and work with people. I understand a flat tire happens, the car won't start, I don't have a babysitter. Life happens, but boy, there's just yesterday afternoon that I had some other patients scheduled and had 3 Medicaid patients. None of them showed up.
Dr. Bobrowski.
Go ahead, Ronnie.
Yeah, I was just going to say that we have the same problem in every state. And in fact, we just raised this issue in a legislative hearing yesterday in Indiana about what could be done. And I mean, people bounce it around, and it's just really hard because some people want to be punitive against the patient. And then if you do that, then they're not going to want to go to the dentist anyway. They're not even going to try. It's like a really hard nut to crack because it's everywhere. And you're lucky if you're in a community where it's not a problem. The other thing I wanted to just mention while I'm on here is that you mentioned, what do we do to keep dentists? Well, I will just tell you, we just closed our Broadway office downtown Louisville, which we had open for, I don't know, maybe 18 years or something like that. It served that downtown community. Rates are the main thing, But, you know, a lot of it was the no show and really the pandemic. And then there's the crime down there, I think contributed to staff not wanting to work there. But I just wanted you to know that we did close that particular office about a month ago, or less than a month ago.
Okay. Well, Ron, I sure do hate to hear that you had to close an office.
Me too.
But
It's just hard to keep providers.
Yeah, I understand you know, and staffing issues, another problem, not only downtown Louisville, but out here in the country. I think I mentioned this before. I was talking with a hygienist the other day or a few weeks ago there, and in the E-Town, like this central Kentucky area, there was 22 offices looking for a hygienist. And I mentioned this to the commissioner. I'm down here in South Central Kentucky, close by to Lindsey Wilson College in Columbia and Campbellsville University over here in Taylor County. And I'm kind of in between them, but I've been thinking about trying to develop a sales pitch and go to those universities and just see and talk to them about opening up a dental hygiene program. I know Campbellsville University is they're doing a lot of different types of programs. They just opened up a cosmetology program. Lindsey Wilson just opened up a nursing program. Maybe it's time to talk to them about a dental hygiene program and get some of our local young people interested in the dental field, because with COVID, like Ronnie, that's what you said, COVID, it just kind of knocked a lot of hygienists out of the system.
Yeah, they just bailed out.
And I talked to another dentist out in the western part of the Kentucky, but he's not a Medicaid provider, but he said, I went 6 months. You know, he's been in practice 20 plus years, 25 years, but he said, I went for 6 months without a hygienist. So that can really slow down the whole process of treating patients when the dentist has to sit in there and do that procedure for half an hour to an hour. You know, you don't get any other fillings done, or you don't get that tooth pulled. So those are other factors involved. But I want to.
Garth, if I can interject on that real quick, I apologize for interrupting.
There's no problem.
I completely understand the sentiment on no-shows and the worries about no-shows, and it is a critical issue. But I think, and I love your concept that we need to get creative on how to address those. I think, however, though, we're dealing with a patient population that has a lot of constraints against them, socioeconomically specifically. And for us to anticipate them to be in the same show rate as every other individual, I think is a farce. I also think that when we focus and compare our patients, we need to be very careful of that and what they are able to achieve and what they're not able to achieve. I think those of us that are on this committee see high rates of these patients. I think we get a lot of complaints from individuals, practitioners that do not see high rates of the Medicaid population, and they complain when comparing no-show rates of their Medicaid population to their non-Medicaid population. You get no-shows from every socioeconomic status. But when you compare the two, it's unfair to the individuals that do have a more difficult time in completing those appointments. For me, it all goes back to how do we get more practitioners to want to see more patients? Why do we have so many no-shows? Some of the no-shows because they wait for treatment, they have difficulty getting treatment because there's not enough providers. And so to address the problem, I think we need to increase our providers and increase the pay for those providers so that each provider understands there will be a higher no-show rate. In our clinics, we have 18 to 20% no-show rate daily. We factor that in. When everybody shows, we love it. It's a very difficult day when they do. But
Yeah.
we factor that in. Now, why do we factor that in? Because we want to see our patients. And that is a challenge. And it is increasingly more of a challenge. It's acutely becoming increasingly more of a challenge because one of the very few orthodontic providers in Eastern Kentucky that does accept Medicaid will close his practice in 10 days. That's going to add another difficulty for those of us out there that are trying to see this population. But if we factor in that no-show and we understand that this population is going to have that, but we're appropriately compensated for the work that we're doing, then we as practitioners need to accept that no-show rate, try to improve it, but understand it and be very careful. And I know that you're not, but many blame the patient when it's not always their situation. And if we can improve things such as the compensation for the providers, we can improve the system, we can increase the number of providers, and we all will not have the worry. I love treating the population. Would I like it to be less of a percentage of the people that I treat? Absolutely. But I'm going to see who needs to be seen. And we're going to have to factor in that no-show rate. But we're not going to get young dentists, young orthodontists, young periodontists, or oral surgeons to jump into this game if they don't have an appropriate compensation for what they're doing, especially with the understanding that there are the negative aspects such as no-show.
Yeah. Good comments. Thank you, Dr. Joe. Appreciate them. Any other ideas or on the how do we get providers back? I just call it, rebuilding our network and, developing plans of care with patients. And I put down the same thing, fees and you worded that really well on, just to acknowledge that there's going to be a failed appointment problem. And just go into it knowing that. But you're right. We've got to take care of people. That's our job. That's our oath.
Well, Garth,
go ahead.
Another big component to this is the hygiene shortage. So, like you'd mentioned, I mean, there's not nearly enough hygienists to service, the needs of the population that's out there. And, you from an economic standpoint, you just have to look at it and go, I can see one population of patients at a certain fee schedule, maybe that's Medicaid, which is, half to a third what we're getting compensated for, for fee for service or, PPO or any of those other things. And I mean, when I can't imagine being, an experienced doctor without hygiene support, and, your day is filled up with, with Medicaid hygiene. I mean, you're going to just lose money all day long.
Yep.
And Joe's right. I mean, you're going to have higher no-show rates. It's not like, people think the only folks that no-show are Medicaid patients. I mean, I have been no-showed by every population there is. It happens, but it is higher with Medicaid. And, if reimbursements were higher, it would be less painful because you would, recoup it on the ones that did show up. And you do have to overbook. So, I mean, if you're having a 20% no-show rate, you overbook by 20%. And like Joe said, some days are real interesting. But for the most part, they're not. I mean, it's just, you end up having kind of a regular day, but you got to overbook. And, patients are waiting forever for treatment. It takes forever to get into an oral surgeon's office. And I mean, I appreciate, everybody who had a part in elevating those oral surgery fees because it kept the oral surgeons in the system. Now, how do we keep the GPs in the system? Just look at what we had to do to keep the oral surgeons in the system by bumping up these oral surgery codes. Look at all the other codes, and that's what we're going to have to do if we want to not only expand the system, but if we want to keep the ones in here. As the economy gets tighter and tighter, it gets harder and harder. compensation's up, supplies are up, lab bills are up, everything's up. But if you're seeing a large percentage of Medicaid patients, you're going in the hole deeper and deeper every day, and that is a tough sell job for any provider to hey, come join us, and you can lose a lot of money. That's not really a good thing. I mean, even with our cost structure, and I mean, we have a lot of offices. Even with our cost structure, there's only so much Medicaid we can see. I was really hard. I hated to hear that, Ruby's closing an office on 18th Street, because that usually means our Dixie Highway office is going to blow up with Medicaid patients. And that's why I know there's such a poor network out there. We can close new patients off at an office, and I'll see an office 20 miles away, 30 miles away. That's where all those patients are going. And what that tells me is there's nobody between there, that's seeing Medicaid, because people don't want to drive any further than they have to. So, I mean, we've got a poor system, and this, while this, increase in the oral surgery fees and some of the other fees is helpful, it's a step in the right direction. The reason Indiana's got so many Medicaid providers is because their reimbursement rates are so much higher. Our Indiana offices, all of our Indiana offices see Medicaid, and they don't complain about Medicaid. And, they don't even complain about the no-shows with Medicaid. I mean, they have them and nobody likes them, but the reimbursement rates are so much higher than Kentucky. It takes some of the edge off, that no-show issue, and just some of the, the behavioral stuff. And I mean, it's sometimes a difficult population to take care of, but it all comes down to fee schedules. I mean, we can dance around it all day long, but it is what it is.
Dr. Schuler, I agree with you. It's all about the fee schedules. And I know in Indiana, they say that's the number one reason dentists don't take Medicaid. But I will tell you that the Dental Association is having a big problem with it. In fact, I testified in front of the Ways and Means Committee last night, specifically on a bill that we're trying to pass that would get the Medicaid dental rates up to the 50th percentile of ADA. And so, and the legislators get it. A lot of them have visited our offices and so on. They're hearing it from their constituent dentist, and they're hearing it from their constituents who are patients. So, but you're right. I mean, we have to do something in Kentucky. And the problem is, in some states, they can make changes without legislation, just like Medicaid did this time with the oral surgeon stuff. And by covering this additional adult population in a way that nobody knew they could do. But when you talk about trying to make a wholesale improvement in a way that's going to be meaningful for like the general population, that almost requires legislative action. And the problem is we can only do that every 2 years. So I think we're going to have to gear up this summer in preparation for next year to try to get the legislative leaders to buy into it. And this is the other thing, and I shared this with Dr. Bobrowski. In Virginia, we were able to get a 30% across the board rate increase last legislative session. We had bipartisan support for it in legislature, and everybody was excited. We thought it was going to make a big difference. And for those of us who are primarily Medicaid, yeah, it was helpful. But again, you're starting at a lower base. And so that 30%, I used this example last night. You use a couple swimming pools. If you got a swimming pool that's 12 feet and a swimming pool that's 4 feet, which is where we are in Kentucky, you increase reimbursement 25%, you just go up to 5 feet. Whereas if you have a 10-foot, and so it has to be meaningful. And the longer they wait, the harder it's going to get. So we're going to have to ask for something substantial. And I think the time to start on it's this summer. Otherwise, it's just going to completely deteriorate in the next 3 years before the following budget session.
Justin, I want to call your attention there to these, just like these adult, they call them prophylaxis or cleaning codes. It's a D1110. I mean, this has just been up to, I know you've got your fee for service set rate, but some of the MCOs take, 10% off of that fee. And the adult code pays $46.25 according to this new fee list. Well, um, you know, Dr. Phil, I don't know what you all have to pay for a hygienist, but you know, it's anywhere from all around $30 to $35 an hour, you know, around our area, give or take on that just a little, but it that you can see right there, you're already almost starting off in the hole by the time you pay the hygienist and then pay her Social Security and withholding, or not her withholdings, but her Social Security taxes and stuff. And of course, we did get it allowed to clean, you know, like once every 6 months. But for a lot of our adults, man, it's those a lot of times have patients that haven't been to the dentist in years. We've had 2 or 3 yesterday. You can't even clean them in an hour. They've got that much tartar and stuff. So I mean, that adult fee. I mean, the child's fee is $60. Even if it was raised to the child's fee helps, but those are fees that you can't keep doing them. And it's like Dr. Phil said a while ago, you've paid a hygienist all day long and you've gone in the hole.
Yes,
So
sir.
that's
Like,
why
again, this is Justin Derringer, and like I said, I encourage you all to put together a list of fees that you think, you know, could be incorrect, that are too low to you know, y'all are having a hard time actually doing the services because they're so low. And then send me that on an email, because it takes time for us to research that. I know we had a discussion before we created this fee schedule, and we looked at the top 10 fees that were billed by dentists. And we looked at every state that touched the state of Kentucky, and the state of Kentucky was higher than the average for each of those states for those 10 codes. So we know those codes in particular, you know, there's no pricing or fee schedule issue with, but you look, that's a large fee schedule. So I'm sure there are codes on there that need some help, but in order to do that, we have to make sure we do the research. We have to do the research on our end to see what every other state's paying, to see what private insurance is paying. And so we have to put all that work in, and then we have to run that through the budget to see if we can get the codes. I know you all know that we attempted to move all of the child fees and adult fees to be the same. That was not in our budget. We're unable to do that budgetarily. So I think, like somebody said earlier, that is something that is taken up and fixed by legislation. Because we don't have that kind of money in the fee schedule or in our budget to be able to make those kind of changes to the fee schedule. I know there are a lot of providers that have gotten no change in their fee schedule this year at all, no increases, and we were able to increase as many things as we could for this 2023 fee schedule. But you know, one of the things that we make sure that we do is, if you find a code that you feel like this is, you know, I can't do this procedure because this code is too low and you know, we can't afford to do it. Make sure that to include that in the list that you send me, and we'll make sure to research that according to other states and again, private insurance pay.
that there's another code there that it's a new code. It's a and I know you all have done this research, but and I don't have to do this code very often, but it's a D5621 and a D5622. But it says to repair a cast partial frame, which is the metal work of a partial denture. The last one I've sent for repair, the lab bill was like $98. And I mean, and you're gonna pay $72.60. See, that's what I mean. It doesn't even cover our lab bill to repair one of those. So, I mean, those are, I know you said you've done your research, but, and even when we use our labs, I mean, we don't necessarily try to find the cheapest lab, but we try to find labs that are reasonable. But the main criteria is when we use a lab is that they do good work. You don't have to refit, you don't have to redo things. You want that partial to fit perfect. Now, but anyway, that's just another one of those codes that we might need to look at. All right, TAC members, let's get her. If you all want to look at that fee list and maybe just send them to me or send. We'll get Justin's. We can either do one list or send them individually. Might be better to do one list of the codes and maybe possible revisions that we need to look at. And then we could get that to them here ASAP and get to going on this. Now, is there any other old business? Okay. The new business, I've got the MLR is for medical loss ratio, and some of these we can put on here for helping us learn your acronyms and stuff. But right now the MCOs, and correct me if I'm wrong, but I think that it's 90% of the capitation monies that you receive go towards patient care. And then the next question I had down there that had come up, who's exactly in charge of the MCO dental contracts? And I'll have to pose that question to someone from the state, please, or an MCO.
Angie, are you still on?
This is Jeremy.
Yes. Jeremy can answer.
Yeah, this is Jeremy Armstrong Dorosset. I am the branch manager of the contract monitoring branch that oversees the state MCO contracts. And so I would be, for the state side, the person who oversees and is in charge in a sense. But any of the MCO's dental contracts that they have with any of their subcontractors, that responsibility would still be on the MCOs.
But now your division, I mean, like who drafts the language for those contracts? Is that your division, Jeremy?
Yes, sir.
Okay.
Not for the dental contractors. This is Angie Parker with Medicaid. The dental contracts are subcontracts of the MCO, and they are the ones who develop the language in the subcontracts.
Okay.
So the MCOs directly contract with the dentist, the dental Avisis, and that's through them. But we do monitor their subcontracts as well.
From my standpoint, I think the reason for asking this question is might not be where Dr. Bobrowski's going, but the problem we have is that the MCOs are taking money off of the exceedingly low fee-for-service schedule. And I know that happens in some other states, but it doesn't happen in other states. I go back to what Dr. Schuler said about Indiana, about maybe people not complaining as much. They haven't increased rates there in a long, long time either, but their MCOs don't take money off the top of what the state's set as the fee schedule. And I know United Healthcare doesn't do that, which is helpful in Kentucky, but others do. And it's over the years, it's been significant. Let's just put it that way. And I mean, it would be one thing if we were all getting paid at like usual and customary, but when you're like 150 to 200% below usual and customary, and then somebody takes an additional however much off, that's not good. And the reason this is important is because in your contracts with the MCOs in the future, it might be a good idea to require reimbursement, at least at the state fee schedule, as they do in Indiana. That way, if we do legislative activism and we have money put towards the dental program to get rates up like we did in Virginia, the money would go straight through to the providers. In fact, in Texas right now, they put language in the budget as they're trying to increase rates so that the money will do exactly that. So I'm glad you raised this question, Dr. Bobrowski.
Well, it's one of those things that, you know, we've just got to look at getting our providers back. And I know the MCOs do a lot of great work for us, but you know, we've all got to get in on this together, or I'm just afraid I'm going to age out here one of these days. I still got 25 or 30 good years left in me, I believe, but that's a joke, Phil. But you know, we like to try to help people as long as we can, but we'll work on that one. But I know Senator Alvarado did have a bill that was going to be presented this year, and may have to work on it this summer again to, you know, to have the MCOs pay at the fee-for-service rate as a minimum. All right, any other questions on that or comments?
Yeah, this is Lauren again from DentaQuest for Anthem. I was just going to add that we are currently paying at or above the current fee schedule, and that went into effect. We backdated it to 1/1 for well, we always have, but for the new fees, they were updated, and we reprocessed all of those for 2023.
Thank you. That's great.
Mm-hmm.
Thank you. All right. Now on this next item is the report requests for the state and the MCOs. Let me see where my paper go. Here we go. I know we've been kind of working on this, and if we've got anything to, and that we can include this, what to go into the report to go to the MAC, you know, on some of these requests. But I know in the past we used to get a multi-page document from each MCO, and had all kinds of reports in those. And there's one that has been particularly of interest is the development of the, I guess y'all correct me if I'm not using the correct term, but I think they were called the geo maps, and kind of coordinating that with a claims paid sheet. And then it may actually be required to have in that report more than one sheet. But I'm not a statistician. I don't do a lot of graphs and things like that and charts, but you all can do this. But one of the things I was looking at was to do a geo map of across the state of the number of, or the providers that are doing anywhere from $1 to $1,000. And I put down here just in my thoughts was that needs to stay there. Of like $1 to $1,000 per quarter, $1,001, another page of $1,001 to $3,000 per quarter, $3,001 to $5,000 per quarter, $5,001 to $10,000 per quarter, and $10,001 on up per quarter. I didn't know if I picked quarter, we could change it to monthly, but I think in the past we've gotten something like that by using the geo maps, think that kind of helps us to see where there's shortage areas in the state. Any discussion from TAC members?
Well, I think you've got, you've kind of got, the state is, tasked with taking care of its people. So, I mean, there's a need to have an adequate provider network. The MCOs are mandated to have a certain amount of coverage in the state. So I think it's provided every 50-mile radius or something like that. I forget. And I think there's a urban and suburban limitation. So, I mean, if the state could put something together based on reimbursements, like you said, because there's a big difference between somebody being a Medicaid provider, and seeing, a couple patients a week, as opposed to somebody who's Medicaid provider and they're seeing 20 or 30 patients a day. I mean, that's a huge difference. And either one of those count as a provider in the network, but they are not the same level of provider. And we know that. So, if you've got a bunch of, providers that are barely doing any dentistry, I mean, we need them. I mean, thank goodness for them, but that doesn't really show the picture. So, if you have some sort of cutoff where you just kind of in your own mind think, okay, if somebody's doing, 10, 15,000 bucks a quarter in Medicaid, they're maybe putting a dent in it a little bit, and I'd like to see that map compared to just anybody who's a Medicaid provider. And I mean, a lot of our offices do a whole heck of a lot more than 10 or 15,000 bucks a quarter. It's a month, and some of them probably a week. But still, it'd be nice to see that correlated to reimbursement levels.
Would you rather see this on a monthly basis instead of a quarter basis?
Well, I think quarterly is fine. I mean, we don't need to get too granular with it, but I think quarterly would certainly paint as clear a picture as monthly. And I mean, you could even do it on a trailing 12-month, rolling 12-month basis. So, you catch any, I mean, if we got that report quarterly, on a rolling 12-month, that would probably do it.
Garth, don't we want to break this down as well by GP and then by the specialties too?
Yeah.
We need to make sure that's in there.
Okay.
Sure.
Yeah.
Because that's what's really going to scare you when you see the specialty. I think we've got the only, there can't be hardly anybody else seeing pediatric patients in the Louisville Metro. Pedodontic, providers. There's a lot of people seeing kids, but they're not pedodontists.
Well, there was another office close by me here that was a Medicaid office. It was a younger guy even, and but he just recently dropped seeing all adults. So that throws them, I mean, I don't mean this in a bad way, but that pushes them over here to me. And I don't mind, but and in another office west of here, they are down to, and the one office, did I say that he dropped all adults? He's only seeing children now. And in another office west of here, they've got another office in another town. They do not see any Medicaid there in that town. The one office they're down to only seeing children too.
So I don't know if the state can actually do any of that work. I mean, I know it's somewhat labor intensive. To come up with that, but
what I'll have to
helpful.
do, is some of these we could asked through the commissioner's office to see if this would need to go to them or do it by MCO. And that, because if we go through the state, they may be only able to give us information from the fee for service part of it, whereas we really need to get that report from the MCOs to see what they cover in their territories. So did somebody want to ask something else?
I was just going to say, yeah, you might see what the dental benefit administrators had to say. I know in Virginia, DentaQuest actually pulls that information and shares it with Medicaid and certain people in the community. So I don't know, maybe Dr. Caudle or somebody could speak to that. If not, I mean, I've found that sometimes you're better off just going to a legislator and having them request the information, and then generally everybody jumps in line and they get it for them, especially if it's a legislative leader.
Mm-hmm.
Hello, Dr. Bobrowski. This is Nicole with Avisis. We would be more than happy to provide that information, but we will have to receive the direction from DMS if they give us the authorization to do that. As I understand, the reporting requests go through DMS, but if you would like us to provide that level of information, we do have availability to provide that. Or I should say capabilities to provide that.
Great. Thank you, Ms. Nicole. Appreciate that.
Dr. Bobrowski, this is Kelly Sheets again. If you would email us and let us know exactly what you want in writing in the report, we can send that on for you.
Okay, thank you. Now, and like I said at the start of this, I'm not one to develop graphs and charts and stuff. I know you all in the past have done those geo maps and can maybe include a methods to put the numbers with that, those amounts of claims paid. It'd probably be helpful if we came up with kind of the same type of design, so that way the reporting matches each other pretty close. And Miss Kelly, I'll email you about that one, and then we'll get that one on the road here.
Okay, sounds good. Thank you.
Thank you.
Garth, let's work on that. But also, I'd like to, if feasible, I would like to see if that could be at our next meeting, that we have that prior to, so we can review it and then be able to discuss that at our next meeting.
I'll make a note there. Okay. We'll get that one done. We've had when I've gone to some of those MAC meetings, we've received some support from other healthcare providers. And I don't know that this has to be any kind of a resolution or vote on or anything, but if we want to, but just I think it's good to the dental TAC, work with other healthcare providers. We're all in this together on even healthcare providers to continue to deal with and work with our state administrators and lawmakers and each other. It's all about taking care of patients is our number one goal. And sometimes we've got to figure out the fine details of getting patients seen, but we just got to work together on that. Like I said, we're all in this together. And then here's another item that, TAC members, we can all encourage our own dental office administrators or our office managers and our staff, for their input on policies in getting this care delivered, to our patients. So that might be just something to, and I'm sure you all do too. I know I try to listen to my office folks, because they handle the paperwork. They see what works, what doesn't work, and what we might need to tweak. But here's another possible report. Let me make a note here. Is to maybe get a report from the MCOs on a list of the prior authorization codes, or the codes that require a prior authorization, and the percentage of denials compared to the percentage of approvals. It may be interesting too to find out, well, what's the reason of the denials? And I know sometimes it's just, well, maybe an X-ray got sent in that maybe wasn't readable, or was the wrong tooth. I know when I send in things, I try to tell my front office people exactly which picture to send in, but sometimes I'm not sure. Sometimes and I don't have much trouble with any of that, but I'm not saying that they couldn't, by the time the phone rings and they're checking somebody in or checking somebody out, that they'll say, which tooth was it I got to send, or X-ray, and which, I think it was this one, and they punch the send button. But I can see where that sometimes could happen. But I don't know, is that an informative piece that any of the TAC members would be interested in, or are we okay with that one?
Garth, I can point out one thing for you about that.
Okay.
As you know, there's clinical criteria out there from the various MCOs and their TPAs. Right. And quite often a doctor will know that a prior authorization will not be approved. But in order to then offer a payment plan, or there's an aunt or an uncle willing to pay for that treatment, even though it doesn't qualify under Medicaid criteria, they still need a denial in writing from us before they're allowed to do that. And orthodontics is a very good example of that, where the orthodontist will check no to every single box saying, I know this case does not meet medical necessity as outlined in the KAR regulations. However, it's more of a cosmetic issue, and maybe there's a grandmother that's willing to pay for this, but I can't bill them until I get that denial from you. So those kinds of things can actually skew the number of denials just because they're sending them in knowing they don't meet criteria.
Okay. That's a good point. I know, I've got that list of criteria for orthodontics close by here, and I'll sometimes I'll do that. I'll just tell the parents or grandparents, I'll say, from what I can see, I don't believe you're going to get this approved, because they just, it's just a couple of rotated maxillary anteriors, and that doesn't meet hardly any of the criteria. So, but like you said, that's a good point, Dr. Cottle, that they might just want that denial. But I kind of, and if they insist, well, I'll give them a referral to an orthodontist. But I don't know what else to do. Just let them get the denial. And but does any TAC member think we need anything else on that one, or we can let it go? Or go ahead,
Garth. I think I'd rather focus on let's get some data wrapped around the provider network, and let's focus on that, and see where we're at there,
okay,
as opposed to kind of layering this on top of it.
Okay, here's another question that might go with that then, Dr. Phil, is just like, well, how many dental providers are in the fee-for-service network? How many are in each MCO? Would that be of any benefit?
We can usually pull the data by reimbursement levels internally. I'm not sure if that would help understanding the full network.
Okay.
Unless there were gaps. If we're getting reports from each MCO, then, we'll be able to see basically each MCO's network. I think that might give us similar information.
Okay. Now here's another question that might go in with that, the geo maps one, was, would it be helpful to have a map or a chart showing where the Medicaid population is in relation to the number of providers for Medicaid?
Like getting an address on these people?
No. I'm just it's
gonna be tough.
Okay. Like I said, I'm not a statistician, so these are just some questions that I've had posed. Some of these are just things that I've had posed to me, and
well, I think if you have a pretty clear picture of the provider network, that because we know people are driving hours, to be seen.
Yeah.
I mean, we hear that over and over again, especially from a lot of our specialists, especially the oral surgeons. I think if there's more information that we want to kind of layer on top of the initial data, I think that we can ask better questions once we know a little bit more.
Okay.
It's just my thought.
That's great. Here is another thing, and I know, and I think it was DentaQuest last meeting mentioned some work they were doing on, and again, I think this is stuff we need to work with each MCO and the commissioner, the MCOs, to decrease the emergency room visits. Last year, there was over $9 million the state had to spend on dental-related ER visits. And I just wanted to put that out there that, that's a big chunk of change. And I told the commissioner once there that, I had a patient from another county, a smoker, that didn't follow our directions and developed a dry socket. We treated it, once here, and we said, we'll come back tomorrow and we'll treat this again if it's needed. Well, she didn't show up the next day. And then she came back later for another appointment a week or two later. But we asked, well, did that get better or what happened? And we didn't see you the next day. She said, oh, I just went to the emergency room and had them treat it. Now the emergency rooms, I don't know exactly what the charge is that they charge the MCO or they charge the state, but I think it's hundreds of dollars per visit. And I told the commissioner, I said, well, typically, if somebody's got a dry socket, we normally don't charge for that. But whereas if they go to the emergency room, it's usually several $100s. So I think we need to work with our MCOs and the commissioner on seeing what can be done to decrease these emergency room visits. Of course, a lot of times it's from what I see is, patients either won't go or can't go for a number of reasons. They won't go to the dentist because I know none of the emergency rooms around here do fillings. Don't see very many emergency rooms that pull teeth. So they kind of doctor them up and, till they said, well, you go see your dentist tomorrow. But I would kind of think we all just need to work together on decreasing the emergency room visits. I don't have any ideas to give you today, but is that something we want to talk any more about today, or I can move on?
Well, I think a lot of that would be helped by having a more robust provider network.
Yeah. Yeah.
I mean, the fact that somebody would go sit 6 or 8 hours in an emergency room to get something looked at, you're not going to get treated, just get it looked at, as opposed to going to a dental office is crazy. I mean, I can't imagine how the ER would be your top choice unless you knew you were going to get, 6 or 8, hydrocodone to get you through. So,
right. Yeah.
And from the commissioner's annual report that was put out, what this state spends on opioids could quadruple, what 10 times what we get reimbursed for dental care. It's incredible what we spend on opioids in the state, and they don't even get treatment. So, no, I think that kind of goes back to the data collection from the MCOs in the state as far as the provider network. We get a better provider network, you're going to drop.
Dr.
I've got
Bobrowski?
one. Yes, go ahead.
I'm sorry, this is Nicole again with Avisa's. Just wanted to share that we do offer an emergency department innovative program that we are currently administering with some of our MCOs and have seen significant results in the decrease of patients are going to the emergency department multiple times. So just as an FYI, we are looking at kind of outside the box to identify ways to encourage members to stay with their dentists, utilize telehealth services as opposed to utilizing the emergency department.
Great. Okay. Thank you. I've got, of course, more and more this last year and even this year, I've got more and more patients that will on I guess it's Facebook Messenger. They'll send me messages about this or about that. Of course, I've heard some dentists say that they'll tell their patients don't do that, but sometimes folks they've gotten rid of their home phones, and a lot of home phones are not in any phone books anymore. But I know at our office here, we've tried to leave a phone number that, and a lot of offices do too, just to an after hours contact phone number. So, the last question I've got is, this was asked by another physicians group or something on pregnant ladies and oral health care. In my mind, I didn't think there was any way using our codes to see if, how many of the pregnant ladies were like, for instance, getting an exam and cleaning. Because I think most of the time we just use our regular exam and prophy codes. We don't differentiate whether they're, pregnant or not. But this was just a question asked about, pregnant moms and oral health care. Anybody got any ideas on that, or just I couldn't think of any way to really, develop any kind of report on that one. All right, I'm going to move on here.
Dr. Bobrowski, it might be a little dangerous for me to guess here, but is there perhaps an ICD-10 code that would show pregnancy? I don't know. That's just a thought.
Yeah, I think so, Stuart. I'm thinking the same thing, and then look and see if they've had identify those members and then see if they've had a dental visit.
Yeah.
Probably is a way to do that. Yeah.
Yeah, you'd have to look at the ICD-10 codes to see pregnancy status.
Correct.
And then use that patient name or that number and then go to the dental record.
Right.
That's a lot of work. That's a lot of work. I don't know.
Well,
I'm just trying to.
Yeah, it would have to be more at the MCO level instead of it just being at the not the subcontractor. It'd have to be like Anthem and WellCare and Molina and the MCO level to be able to pull that data together.
Is that something that would help us on any kind of treatment planning? Or, I mean, to be honest, the pregnant ladies that come to our office, we don't see a lot of. I mean, yeah, every now and then we might have to pull a tooth or do some fillings, but I really don't see anything different than any other patient.
Right.
I think that stipulation was removed in the new iteration of the car.
Okay. Well, all right. Let's just move on that one there. Are there any other reports that the TAC members would like to move on to the MAC? I believe the main thing is just developing our what we first talked about on that, and then I can get that to Miss Kelly, and then I believe our folks there can work on that one. I'm not seeing anything that we need to report to the MAC, unless you all have got something else. All right, I'm gonna move on real quick to usually in the past, we would have election of the chair and vice chair for the TAC, at the first meeting of the year. Now, was researching that with one of our helpers there from Frankfurt, and we were talking about, well, maybe through the MAC regulations, that's done at the first meeting of the fiscal year, which would put that up in the summer. Now we could have nominations made, either like at our meeting today or at our meeting in May, and then our meeting there, August meeting, we would have our vote. But we do have to probably have the nominations, maybe a meeting before, and then that would be put on the next agenda to actually vote on. That's just kind of what I was going by on the MAC rules.
Dr. Bobrowski, this is Erin with DMS.
Yes.
If you guys would like to make your recommendations or your nominations in this meeting, and I would think your May meeting would be close enough to the fiscal year that you guys can make the vote on that, so you don't have to wait till August. But that's completely up to the TAC.
Okay. Oh, let's get our nominations in, and then we can do our vote in May. We're just kind of going by the rules of what are stipulated in the MAC rules, but let's have nominations in for the chair and nominations for the vice chair for the TAC. And the floor is open.
You're asked to do it again. I nominate you to be the chair.
Okay.
Me too.
Okay.
You said you number 2, Phil, you vice chair. Is that what you were saying?
No, I said me too on Garth as the chair. I mean, I'd be vice chair. I don't care.
Okay. Well, we've got nominations.
Me and
for,
Garth talk often enough anyway.
Yeah, we could, is there any other nominations? Hearing none, we'll just vote on both at the same time, but for me being the chair and Phil to be the vice chair. And then I guess we'll have to just have those nominations and actually vote on it in May. But
Yes.
We'll vote. I guess everybody favor aye. We'll just put those two names on the ballot then in May.
Aye.
Aye.
All right. Thank you all. Now, is there the one thing that's very important that I do not want to leave off today is we want to wish Miss Erin the very best because she's getting ready to go on maternity leave.
Oh, thank you, Dr. Bobrowski.
So
24 days.
Oh boy. Well, we truly do want to wish you the best. And is it a boy or girl?
It's a boy.
Okay. Well, I've got.
I appreciate that. Thank you.
Yes. Is there any other new business that we need to bring up?
Garth, I know.
Yeah.
You know, in the past, we've had a spot at the end for any public comment. I looked on the participant sheet. I couldn't tell if there were any private dentists out there, but we should probably leave a little gap at the end to, if any private dentists or any other providers are on the call, if they have anything they'd like to say to the TAC.
All right. The floor is open now for if anybody on the call list would like to make a comment or have an opportunity to make a recommendation or for something for the TAC to look into or whoever.
Doesn't sound like got any takers, but just wanted to throw it out there.
Yes, thank you. Well, a lot of times if you'll notice on the agendas, I'll try to put on there either, like you said, public comment or other comments or other, especially like in old business, just so I don't forget something. And I did today. I forgot to put on there about approving the minutes. And then, and I swear inevitably, if that I'll try to get the agenda out at least I'll try to do for 2 weeks. The last two it's been a week, but inevitably there's always been something that'll come up that's like, oh man, we need to talk about that. We can't really wait another 3 months on that. So that's why I put that other on there, is just to kind of help speed up the process on things. But our next meeting will be May the 12th, 2:00 Eastern time. And boy, I really appreciate everybody's input and thoughts and comments. All we can do is just kind of keep working together and try to do what we can to help our patients and we just to work on our provider network. I think it's critical because if we work on our provider network, it really helps our patients. But that's all I've got. Thanks everybody. Hope everybody has a good weekend, and do not forget that next Tuesday is Valentine's Day. So treat your Valentine extra special.
Most important holiday of the year.
That's right. Well, thanks everyone.
Have a great weekend, everyone.
Thank you.
Everybody have a good one.
Everybody have a
Bye-bye.
good one. Take
You
care.
too.
Thank you so much.
Thank you.